to welcome everybody, the audience, our speakers today, and my fellow moderators. And we have 4 very interesting talks for you to listen to, and then we will have a Q&A session at the end. We've heard all the talks, and I would encourage you to please send your questions, and we will try and address those questions at the end. And also, I'm told by the STS that I should encourage you all to join the quiz at 6 p.m. This evening. So, without further ado, I'd like to introduce Dr. Sadhna, who's going to present our first talk on dual antiplatelet therapy.
Thank you for inviting me to talk on bilateral internal mammary arteries, technical tips, and the evidence. Cleveland Clinic published their results on the use of bilateral internal mammary arteries with a 20 years follow-up. They provided a comparison of matched pairs of patients having bilateral versus single IMA. They showed improved overall survival in the BIMA group, improved survival for various subsets, such as left ventricular function, and the magnitude for increased survival benefit over 10% at 20 years. If you look at the second graph carefully, where the subsets of left ventricular function against the use of bilateral versus single IMAs are displayed, one can see clearly that the bilateral IMA with mild left ventricular impairment have the best survival at 20 years compared to the single IMA with moderate to severe left ventricular impairment. But watch the other 2 curves closely, where this single IMA in patients with mild left ventricular impairment and bilateral IMA patients with moderate to severe left ventricular impairment almost coincide, clearly showing survival benefit in patients who have bilateral internal mammary arteries. These findings were echoed by the Japanese group. The paper published by Endo and colleagues in Circulation 2001 showed the benefit of bilateral over single internal mammary artery grafts for multiple coronary artery bypass grafting. They presented their early and late results of over 1,300 patients undergoing surgery split between these 2 groups, with a median follow-up of 6.15 years. The hospital mortality was similar. The graft patency, however, was considerably better in the bilateral IMA group at 97% versus 94% in the single IMA group, with a p-value less than 0.0001. Similarly, the 7-year repeat CABG free rate was higher in the bilateral IMA group with a p-value of 0.026, and the hazard ratio for death or repeated CABG in patients with ejection fraction over 40% and age under 71 years was lower in the bilateral IMA group. This was followed by a systematic review of studies comparing bilateral and single IMAs by David Taggart, published in The Lancet in 2001. Bilateral IMA was shown to have significantly ratio for death at 0.81. Of course, the arterial revascularization trial followed this analysis, and a randomized trial of bilateral versus single IMA in over 3,100 patients was undertaken. The 10-year outcomes showed no significant difference between the 2 groups. However, the trial did not take into account the effect of radial artery. 22% of the single IMA patients received a radial artery graft which would improve the single IMA group outcomes. And 14% of patients in the bilateral IMA group actually received a single IMA, and the intention to treat analysis will treat this cohort as bilateral IMA. Therefore, the ART trial failed in its fundamental quest to address the issue of bilateral versus single IMA, and the ROMA trial is currently underway to answer this question in the setting of a randomized controlled multicenter trial. What are the prerequisites for the surgeon in terms of mammary artery harvest? The surgeon wishes to have good conduit length, excellent conduit free flow. Both conduit and chest wall hemostasis should be adequate. The ability to perform Y grafts and sequential anastomosis, and of course, sternal wound healing. From a patient perspective, patient would want to have reduced sternal pain and discomfort, reduced chest wall numbness and altered sensation, what we would call dysesthesia, a well-healed sternal incision, a durable operation, and of course, where applicable, an operation that would avoid stroke. Which brings us to the discussion about skeletonized internal mammary artery harvesting. There is a randomized double-blind within-patient comparison of pedicle versus skeletonized mammary artery harvesting, which was published by Budwani in Circulation 2006. It showed that a skeletonized mammary harvest could produce a longer conduit, increased free flow after connection or disconnection of the distal end, decreased pain on visual analog score at 4 weeks and at 3 months, reduced chest wall sensory deficits at 3 months, and significantly better sternal perfusion as seen on nuclear imaging. Particularly, the concern revolves around patients with diabetes. There are 2 papers that have shown skeletonization of bilateral internal mammary arteries lowers the risk of sternal wound infection in patients with diabetes. The first one is by Peterson in 2003, who showed clearly that deep sternal wound infection occurred in 1.3% of skeletonized mammary patients versus 11.1% in the pedicled mammary patients, with a p-value of 0.03. Likewise, a more recent paper in 2019, published in the Journal of Cardiothoracic Surgery, has shown that skeletonization contributes to a reduction of sternal wound complications in a study of patients who had off-pump coronary artery bypass grafting. In this paper, the overall incidence of sternal wound infection in diabetic patients was 8.5% when it was skeletonized, as opposed to 19.8% when it was pedicled harvest, with a p-value less than 0.02. And there is this nice paper from Cohen et al. Over 20 years ago that shows nicely on a technician SPECT scan of pedicle IMA harvest a considerably reduced uptake on a nuclear imaging after pedicle harvest compared to preoperative state. And in a skeletonized harvest, there is virtually no change from the preoperative state, showing that the vascularity is not compromised when undertaking a skeletonized harvest. So what are the caveats of skeletonized bilateral IMA harvesting? One has to negotiate the learning curve, and the time will come down with increasing experience. There are limitations with comorbidities, particularly in patients with diabetes, COPD, and obesity. And certainly if there is 2 out of 3 of these comorbidities, it would be wise not to take bilateral IMA. Chest wall hemostasis is very important, both in terms of adequate sternal vascularity, but also in terms of avoidance of reopening of patients. And of course, with the proximal end of the mammary arteries being harvested, attention to phrenic nerve is important, as bilateral phrenic palsy is a potential complication if undue care is not given when this is done. So I've put up this video of skeletonized mammary harvest. The endothoracic fascia is incised with diathermy, and careful dissection is undertaken between the medial internal mammary vein and the artery. Careful attention is paid not to damage the vein in this process. Individual mammary artery branches are carefully dissected out, and liger clips are applied close to the mammary artery, and diathermy is used in a low-grade setting to disconnect distally. Where the artery is dissected away proximally, liger clips are applied on both sides because the mammary branches tend to be bigger and sometimes shorter. Adequate space between the clips is important to allow division of the artery carefully. As the branches are divided, the artery tends to gradually come down easily. This is the right internal mammary artery being harvested. One can see the bifurcation of the distal end of the right mammary artery. Careful attention is paid to chest wall hemostasis. And one can see that the artery alone is dissected, leaving the branches secured as one goes along. At the proximal end of the right mammary harvest, the vein is dissected out and carefully divided between liger clips to allow access as proximal as possible to ensure that the right mammary artery harvest is completed. The artery tends to gradually dilate under systemic pressure, and this is further enhanced when the artery is disconnected at the distal end. One can see that the distal end is rather small at this stage. However, with occlusion with a lighter clip and allowing the artery to dilate with topical papaverin and systemic blood pressure, the artery tends to dilate to a considerable degree. And this is the bilateral mammary artery harvested. So we've got this other video clip that shows you the arteries being used to do the bypass operation. So I tend to use the right internal mammary artery across to the left anterior descending. There is plenty of redundancy, and the artery is tucked away under the innominate vein and the thymus, well away from the sternum. The left internal mammary artery is opened on its side to perform a side-to-side anastomosis to the intermediate branch of the circumflex artery, and a shunt is in place, which is removed prior to completion of the anastomosis. The distal end of the left internal mammary artery is now being used to perform the second anastomosis. The bulldog is hanged on a thread to make sure the weight does not fall on the proximal anastomosis. One can see that there was excellent distal blood flow. And that is the completion of the second anastomosis using the left internal mammary artery. We perform transit time flow measurements following these procedures, and one can clearly see that the right internal mammary artery to the left anterior descending has a flow of 33 mils per minute with a pulsatility index of 2, and the sequential Lima has more than twice that flow due to the larger myocardial bed it serves at 74 mils per minute and a PI of 1.4. And this is a good illustration of how the mammary artery is able to increase its flow depending on the demand placed on it. So in summary, skeletonized bilateral IMA harvest offers some distinct advantages, such as conduit length, conduit diameter. It mitigates sternal wound infection, especially in diabetic patients where it is more relevant. Facilitates Y grafting and sequential anastomosis. It promotes no-touch aortic technique and off-pump CABG where applicable, and allows in situ independent bilateral IMA inflows as a consideration in the coronary artery grafting strategy. There is a learning curve to this approach, and trainee surgeons can be taught this valuable technique to benefit our patients. Thank you for this opportunity to deliver this lecture.
Center in New York to present his talk on the role of the radial artery in CABG surgery, indications and technical consideration. Mario.
So thank you for the privilege of being part of this meeting. My task is to discuss the role of the radial artery for coronary artery bypass surgery with specific regard to indication for its use and technical consideration. So the first point when approaching a patient that is a potential candidate for CABG using the radial artery is that there are some clinical exclusion criteria, clinical contraindication to the use of the conduit. The first classically is trauma to the arm, vasculopathy, some form of vasculopathy that typically affect the arm. Renal failure is not formally a contraindication. However, in patient with renal failure, it is important to consider that the radial artery may be needed down the line for the performance of arteriovenous fistula. So some consideration about the risk versus benefit of using the conduit for CABG must be given. Previous transradial approach for catheterization of percutaneous intervention is not, again, an absolute contraindication. Current guidelines recommend at least 3 months between the transradial approach and the use of the conduit for CABG. However, it must be highlighted that those guidelines are not really evidence-based. We know that the use of the transradial approach is associated with significant endothelial damage in the radial artery. What we do not know is when the endothelial damage heal and if endothelial function at some point get back to normal. In my personal practice, I tend not to use the radial artery after previous transradial catheterization at all, if possible. There are different methods of assessing the adequacy of ulnar compensation to radial artery removal, but this is really a key point of the use of the radial artery. Ischemic hand complications are definitely unacceptable after radial artery harvesting. I strongly encourage everybody to use some form of objective instrumental evaluation of the ulnar collateral circulation. The clinical Allen test alone is highly operator dependent, and I don't think it should be trusted. Some, again, form of objective evaluation of the consequence of radial artery removal are needed. There are still different options. You can use oximetry, echo Doppler, or plethysmography. Echo Doppler has the advantage of providing also information on radial artery diameter and potential presence of calcification. Mockenberg calcification is one of the potential problems of the radial artery that may make the conduit not fit to be used for CABG. Whatever method you use, a drop of 50% of less or either flow or oximetry at the second digit is generally considered a sign that the radial artery can be safely harvested from that specific arm. Target vessel criteria, very important. The radial artery is highly susceptible to graft failure due to chronic competitive flow. The traditional angiographic criteria was 70% for the left coronary artery and 90% for the right coronary artery. I don't think the angiographic stenosis per se tells the whole story. We'll get back to this soon. Fractional flow reserve below 78 is definitely a good indication for the use of the radial artery. Personally, I use the ratio of between the diameter of the radial artery and the residual lumen diameter of the target vessel, and I aim for a ratio of 1.2 or above. And this is why I believe that echo Doppler is the best screening method for the evaluation of the radial artery before surgery. The reason why I do that is because angiographic stenosis per se, again, does not tell you the whole story. It's not the stenosis that is important, it's not the percentage of stenosis, but what is important for in terms of competitive flow is the residual diameter of the target vessel. 70% stenosis on a huge right coronary artery lead to a completely different amount of competitive flow that 70% stenosis on a 1 millimeter OM2. Harvesting technique, atraumatic, this is the key. There is no real evidence if the open or endoscopic technique is better. The endoscopic technique is associated with better cosmetic result and probably a faster recovery of the arm function. There may be a reduction in paresthesia or neurological symptom after harvesting, but we do not know what is the effect of use of one or the other technique on radial artery patency and clinical outcome. There have been a number of studies, but they are all been small, and even using a meta-analytic approach, the current evidence is largely underpowered to detect even large difference between the groups. So I personally use the open technique, but this is just because this is how I've been trained. I think the endoscopic technique is also fine. We need definitely more data on that specific topic. In terms of vasodilatation, this is key when using the radial artery. Different solutions have been proposed. I personally use papaverine, but Mirinon, nitrates, and verapamil are all possible alternatives. I believe that it is key that whatever solution you want to use, administration is not only endoluminal, but also subadventitial, as is shown in the lower panel of this figure. The reason for that is that the radial artery has a very thick wall, and the vasa vasorum do not reach the outer third of the media. So endoluminal administration alone will result in incomplete vasodilatation and will not reach the outer third of the media that is highly muscular. It is also key to fully open the fascia that cover the radial artery in order to allow maximal vasodilatation, as is shown in the upper drawing on the right side of the screen. It's also important to maintain normothermia. The radial artery is highly sensitive to temperature and react with spasm at lower temperature. In terms of postoperative vasodilation, well, the evidence is really limited. We have published one of the most solid piece of evidence so far, a post-hoc analysis of the radial database, where we found that the use of calcium channel blocker for 12 months was associated with a better patency rate and the lower rate of MACE among patients with radial artery graft. So I personally prescribed low-dose amlodipine for at least 12 months after surgery if tolerated, but again, the evidence is definitely not solid on this topic. Proximal anastomosis can be performed on the aorta or on the internal thoracic artery. We have compared the two. The patency rate is similar, however, as expected, ITA anastomosis, the radial artery, are more at risk of graft failure due to competitive flow. The DP/DT is clearly higher for aorta anastomosis conduit. So my recommendation is to use the aorta as a proximal anastomosis every time there's a concern for competitive flow, but more in general, I use the aorta as an inflow source in the overwhelming majority of my cases. The radial artery length is enough to reach every target vessel, even the PDA from the left, when anastomosed to the aorta. So I don't see the reason to use the ITA as the proximal anastomosis, but this is a matter of personal preference, and potentially that can allow the use of anaortic technique. So my conclusion: the radial artery is a versatile and user-friendly conduit for coronary artery bypass surgery. There are key steps for its use. First of all, objective preoperative assessment of the ulnar circulation is key. Harvesting must be atraumatic, either open or endoscopic. Intraoperative preparation and vasodilatation is very important. Opening of the fascia and subadventitial administration of the vasodilatory solution as tips that, in my opinion, are important. And then target vessel selection and avoidance of competitive flow situation are also very important.
Thank you, Mario. That was a very good talk.
Thank you for the
and
attention.
as I said, we'll take questions at the end
of
of all four talks. So now it's my pleasure to introduce to you David Glenier. He's a cardiac surgeon from the University of Ottawa Heart Institute, and he's going to talk today on the use of fractional flow reserve and insight from the IMPAG trial. David?
Mr. Chairman, dear colleagues, the purpose of my talk today will be focused on the use of fractional flow reserve and the insight of the IMPAG trial. I have nothing to disclose. Already in 1984, in the New England Journal of Medicine, the president of the American Heart Association was concluding that there is a definite need for improved analytical methods for the physiologic assessment of angiographically detected coronary obstruction. And so already since then, cardiology has tried to find a better way to evaluate the severity of coronary stenosis. Why is that? Because when we do what we do every day in the cath lab or in the operating room before bypass surgery, when we evaluate by visual inspection coronary stenosis, we transform a 3D lesion into a 2D image. And so as you can see on the left example here, it's very easy that we underestimate the lesion, and on the right side in one view we can very easily overestimate the lesion. So eyeballing visual estimation will lead to significant misdiagnosis of lesion severity and or non-severity. Moreover, the visual estimation does not give you any information around the fact of what kind of flow do we have in the lesion. Is it a favorable flow, or is it a turbulent flow? Is the lesion localized, or is it very diffuse? Therefore, cardiologists have proposed to use a more physiologic method, which is fractional flow reserve. Fractional flow reserve, to make it simple, is just a measure of pressure. And this is crucial. What we will always evaluate is the pressure before and after the narrowing. Whether it's a long narrowing, a short narrowing, it's a ratio of pressure. And I will come back many times around this principle. So all the studies around FFR, whether in cardiology or in surgery, were based on this study from 1996 from Pales and colleague in the New England Journal of Medicine. Is the correlation between the FFR measurement in significant lesions and 3 different tests: an exercise test, thallium scan, and a stress echocardiogram. And they found that at a cutoff of 0.75, the vast majority of these tests were significant below 0.75 and not significant above 0.75. So everything around FFR is based on this paper. Now, what you have to know is that FFR is very precise and gives you all information, even if you have collateral, even you have had a myocardial infarct, you have a scar in the muscle that is fed by the coronary artery that you evaluate. So FFR is highly accurate it's lesion specific. It has a clear defined cutoff value. We know from the cardiology world that not stenting an FFR negative lesion is safe. It's the DIFFER trial. Treating FFR positive lesion improves outcome. That's the FAME trial. And what is very important for a surgeon is that in the sub-study of the FAME trial, they looked at lesions between 50 to 70% with eyeballing, and 65% of these lesions did not induce ischemia, so were negative in terms of ischemia driven symptoms and or angina. What you have also to know is that our graft, arterial graft, mammary graft, and vein graft will react completely differently against competition flow. How do we know this? Well, we did some FFR measurement in the graft to know what was the resistance between a left mammary, a right mammary, and a vein. And as you can see, where you have to focus on is here, the vein, there is no pressure gradient drop. This means that if you have a 100% millimeters of mercury in the aorta, at the beginning of your vein, you will have 99 millimeters of mercury at the distal anastomosis. While if you have a mammary to LAD, as you can see here, you will have a 10 to sometimes 15 millimeters of mercury gradient drop. So if you have 100 millimeters of mercury in the left subclavian, in the distal anastomosis, the pressure will only be between 85 to 90 millimeters of mercury. And this is the explanation why we have more competition flow and why FFR could be useful in arteries, and it's not going to be useful in veins. And this is clearly demonstrated by this study by Karapatos, who looked at the flow in the left mammary to LAD in regards to the degree of stenosis of the LAD. And as you can see, once the stenosis increases, the flow of the left mammary increases and the PI decreases. This is the explanation of why, once again, FFR is useful in arteries, because it will allow you to predict how much competition flow you're going to have and how much impact it's going to have on your arterial graft. So the principle of all this would be that if you have a 70% stenosis leading to a negative FFR of 0.89, if you use a vein, as you can see, the pressure in the aorta is 100 millimeters of mercury, at the end is 99, you have no competition flow, the vein works, despite the fact that the FFR is negative. But if you use a mammary will have a decreased pressure drop throughout all the conduits, so that at the end of the mammary, at the distal anastomosis, you will only have 92 millimeters of mercury, so you can have a high competition flow. So this is the explanation of what FFR could help for. So let's look in detail what is in the literature between FFR and bypass surgery. I think that the most two important questions are, does FFR improve graft patency, and does FFR improve clinical outcome? Let's first have a look at FFR and graft patency. So the Milestone paper is from 2007, Botmine paper, who looked for the first time ever at the correlation between the pre-op FFR and the graft patency, and you can see that they found a significant cutoff of 0.8, below which the number of occluded grafts significantly decreased. After this, Onda and al. In 2015 correlated the pre-op FFR with the graft flow, and as you can see, once the FFR goes up, the flow decreases. When the FFR goes down, the flow increases, and it's also true with the reverse flow. When the FFR goes up, you can see that you go up to 28% of reverse flow. Once the FFR is below 0.7, there is only a 7% of reverse flow. So for this reason, we decided to perform a prospective trial called the IMPAG trial. The IMPAG trial was, the hypothesis was that FFR could allow the surgeon to plan surgical grafting and better correlate the patency of arterial grafting over a conventional angiography, and FFR could decrease the risk of high competition flows, and we only looked in arterial grafting. So this is the flow chart of the trial. Patient came with 3-vessel disease, the benefit of a regular angiogram. They found that they had a syntax score above 17, so decided to go for surgery. An FFR was performed in the 3-vessel in order to measure in each specific lesion FFR value. Patient was sent to surgery, benefited of a complete full arterial grafting, and came back 6 months after to have a angiogram in order to correlate the patency of the graft, the functionality of the graft, and the pre-op FFR. So the primary endpoint is to evaluate the impact of preoperative FFR on arterial bypass at 6 months, and secondary endpoint was to correlate this with graft configuration and graft functionality. We were able to include 63 patients, 199 anastomosis were analyzed, 68 were sequential grafting, 86 had 2 mammaries, Y graft configuration. Mean syntax score was 22, mean target size was 1, 75 millimeter. Most of them had a good target, and 49, so 78% of the patients were performed off pump. So this is the results. As you can see, we find a cutoff of 0.78, below which 98% of the graft were open, above which where we had a mixed bag of balanced, occluded, perfect, and reverse flow. This is another way how to express this finding. On the right side, you can see that above 78, most of the graft were non-functional, while below 78 on the left side of the graft in the red dots, most of the arterial anastomosis were functional. Now, very interestingly, we found a significant difference also above 78. If you use sequential grafting, as you can see on the extreme right, the number of occluded graft is significantly lower than when you use non-sequential grafting. So sequential grafting in a negative FFR lesion above 78 helps to keep the graft open, because the hypothesis is that it increases the flow through the graft. And also, very interestingly, when we looked at where the sequential grafting was, is that if the sequential grafting was on the lateral wall versus the RCA distal wall, there is a very significant difference in favor of the lateral wall versus the most distal anastomosis on the RCA. So the PDA is the worst scenario when you have a negative FFR above 0.78. So we concluded that for the left grafting, in order to have a functionalized arterial anastomosis, you need to have an FFR above 78. And for the right side grafting, you need to have a much lower at 0.71 of FFR. So we concluded that FFR, but not angiographic stenosis severity, was a predictor of arterial anastomosis patency. And when you use a cutoff of 0.78, you have 98% of patency. The second question is, does the use of FFR improve clinical outcome? There are 2 prospective randomized trials. The first one is the FARGO trial, which is a prospective randomized trial comparing angiography-guided versus FFR-guided bypass. Primary endpoint was patency at 6 months. Secondary outcome was MACE. 70% of the graft were veins, and the result is that there is no difference in patency or MACE. Unfortunately, this trial has significant major bias. First, it's underpowered. Secondly, 25% of the patients were lost at angiographic follow-up. Third, the study stopped at 58% of the planned enrollment, so it's completely underpowered. And 12%, there were 12% of operative protocol violation. The second graph is the GRAFFITI trial, which is also a prospective randomized trial looking at angio versus FFR-guided bypass. Patency at 1 year is the primary endpoint. Secondary endpoint is MACE at 1 year. 50% of the graft were veins, and the result is that there's no difference in patency and or MACE. Unfortunately, here too, there is significant major bias. They only reach 83% of the planned enrollment in these patients, so the study is underpowered to detect anything. 37% were lost at angiographic follow-up. This also explains why it's underpowered to detect anything. And there was 40% of major protocol violation, such as 29% of the deferred vessel had a significant FFR below 0.8, and 11% of the bypass vessel had a negative FFR above 0.8. So for these two reasons, and due to the underpowered, prematurely stopped plan enrollment, incomplete angiographic follow-up, and the very high rate of surgical protocol violation, it's very difficult today to use FFR to decide whether or not a graft should be bypassed. However, I strongly think that FFR could help you in order to decide whether or not in a young patient you should use a full arterial grafting or use a vein dedicated to the moderate lesion. And this will allow you to better plan multiple arterial grafting in young patients. I thank you for your attention.
Okay. Thank you, David. That was a very interesting presentation, and I'll see if there are any questions from the audience.
I think one of the questions we have here is, and for diffuse targets, what is the strategy for grafting? So perhaps that will impact on what we've heard recently in the use of FFR, but also in the use of perhaps radial artery grafting. It's a very open question, really. If there's not a discrete stenosis, but there is, if you like, diffuse disease in the coronary artery, how does that impact on your choice of conduit?
Well, I can start. So the typical example is diabetic patients with very diffuse disease. Even if with eyeballing you have the impression that you only have 50% narrowing, once you ask your cardiologist to repeat an angiogram with FFR and they do a pushback from the apex of the heart, the distal part of the LAD, and they pull the FFR catheter back to the proximal part of the LAD, you often see that the more they pull, the higher the FFR goes. But the diffuse disease, specifically in diabetic, often leads to positive FFR. So once again, once it's the LAD, the patient is diabetic, I would still definitely use mammaries. And of course, for the lateral wall and the inferior wall, if there is any doubt and the patient is young, I will still consider asking a repeat angiogram if a FFR has not been performed in the primary angiogram. Because this, of course, gives you a lot of information. However, if you don't have that possibility, as I've explained in my talk, I think a vein is always a good idea, but I will definitely not use a radial in this specific context.
Okay, thank you. And I think there was another question which was for Mario, and that was, how do you decide when you're going to use a BIMA versus perhaps a lima and a radial artery in a patient?
Well, I think it's there are two main considerations: target vessel anatomy, and also surgeon preference and experience, as well as key patient risk factor. In patients who have a high risk of sternum wound complication, I think that is a no-brainer. If you can use a radial, it is better. If this is not the case, well, in case where you cannot use the radial artery because there is no ulnar compensation, also is no-brainer. All the rest is a gray zone where, again, surgeon experience and comfort with one configuration or the other play a key role. In my experience, above 70 years of age, I don't even consider using beta. My second conduit is by default radial artery. In younger patient, if I can use a beta, to in situ beta, that would be my preferred operation. If I have to use a free graft or if I have to rely on a Y graft, I would probably use a radial from the aorta.
Yeah, thank you very much, Mario. I don't think we have any more questions from the audience, but I have a question. Sigrid, thank you for your talk. It was very enlightening and I really enjoyed it. Can I ask you, I think at the moment from where I'm sitting, it seems that we're being very much led by the cardiological experience in acute coronary syndromes in terms of how we treat our patients, particularly after CABG surgery following NSTEMI or STEMI. Do you think we should be moving to more sort of, if you like, objective assessment of our patients and using platelet function tests to see how they respond to P2Y12 inhibitors or aspirin before we decide if they're going to go on single or dual platelet therapy?
Well, I think that's basically not such a bad idea to do because, as I've mentioned, 1/3 of patients who receive clopidogrel are actually not going to be responsive to clopidogrel. Whether this is going to be, doable in a surgical clinical setting, I couldn't say. I know that we don't do it. I don't know if it's practically applicable, but it's certainly something that would be, I think, for the benefit of the patient.
Yeah. Can I just ask my fellow moderators and the speakers, how many of you actually use DAP therapy in that clinical scenario following, having undertaken a CABG and a patient's had an NSTEMI? Do you all put them on DAP therapy or are you still using monoplatelet therapy, antiplatelet therapy?
Well, we use dual antiplatelet therapy for almost all patients, at least for 6 months.
Me too.
Sometimes, yeah.
Interesting. Okay, so that's regardless of if they had stable coronary syndrome or...
Yes, yes.
Can I ask you a question to Sigrid? Sigrid, do you have an opinion about the treatment for patients who have multiple arterial grafting or total arterial grafting in terms of anticoagulation? Would it be different with veins than with patients with veins?
So I think the treatment strategy is different for patients who receive multiple arterial grafting, and there is actually a meta-analysis looking at the benefit on arterial grafts versus venous grafts. Obviously, they were also studies which included a lot of patients after acute coronary syndrome, but it showed very clearly that while there was a benefit on patency for vein grafts, there was absolutely no benefit for arterial grafts. And in fact, there was harm for patients who had received multiple arterial grafting in a sense that there was just more bleeding. So this is something that I would definitely not recommend for patients undergoing multiple arterial grafting for stable coronary artery disease. There is, to my mind, no evidence that there would be any benefit of dual antiplatelet therapy.
Okay, thank you.
I have one question for Mario. Mario, you mentioned about amlodipine for patients who have had radial grafts. So is that a routine practice to give amlodipine to all your patients who have radial arteries? Or do you give amlodipine to everybody?
No, amlodipine is only for patients with radial artery graft. I have gone back and forth with calcium channel blocker over the course of my career. When we started, diltiazem was the choice, and then we learned that diltiazem was probably not effective on the radial artery. For a pretty long time, I just abandoned the use of calcium channel blocker. And I know many high radial artery users have done the same. But then after the post-hoc analysis of radial that show a benefit both in patency rate and in clinical outcome for patients that receive calcium channel blocker therapy, I went back to use at least something for the first year, and amlodipine as probably the best risk profile and efficacy on the radial artery. So in absence of solid data, if a patient can tolerate low-dose amlodipine, this is my practice. We are designing a trial to test the effect of calcium channel blocker therapy on radial artery graft. So hopefully in the next few years we will have a better answer.
In Edinburgh, we don't use amlodipine regularly. In fact, the management of patients who have radial artery grafts is just the same as other patients. What about my colleagues over here? Bala, Sunil?
I think, like you, Mario, I stopped using calcium channel blockers for radial artery grafts, and I haven't up to now gone back to prescribing them, but your talks made me think again, and maybe I'll be looking at the evidence again for using calcium channel blockers. Thank you for that.
What about you, David and Sigrid? Do you use?
I systematically use it as Mario. Amlodipine on all patients with radial artery grafting for 6 months.
David, I have a quick question for you, because I think this whole business of using FFR in helping us to, if you like, plan our operations better is a very exciting prospect. At the moment, we're limited very much by what the cardiologist can do, in the sense that it is an invasive procedure. And on the horizon, of course, is CT FFR, and that's already, I think, now available. I think Mario could probably shed some light as well in the States. CT FFR is here for cardiological use, but it's not yet, I understand, available for CABG patients and CABG planning. Do you see that as something that's going to happen soon for us as surgeons?
In my personal experience, I'm not a super fan of the angio CT FFR, as well as the always makes me smile when I see studies, cardiac surgery studies that use CT to observe patency after. It works very well for veins. It does not work for arteries. So doing CT angiogram post-op to control the patency of arterial graft, in my view, it's a mistake, because I had many patients that had a pseudo CT saying that the graft was occluded. You send the patient to the angiogram and it's open. Why? Because there is competition flow. Competition flow reduces the flow in the graft, and so with the CT, you don't have the same accuracy than with a regular angiogram. That's another discussion. But to come back to your first question, there is, I think, a new reversionary test that will definitely change the spectrum of how we use FFR, which is the angio FFR. So it's the new tool. There is 3 companies that are proposing this now. And so you do a diagnostic angiogram, and if you have 90-degree angle views, they can, just with the software, allow you to have a 98 accuracy with the regular FFR. So you will get your FFR value just by putting your images through a software.
Right. Yeah. Oh, that sounds very exciting.
That's very exciting, yes.
It is indeed.
It's once again going to be very expensive, but it's very exciting.
Yeah, I didn't ask you the cost, but yeah, there's always a sting in the tail. Okay. I don't think there are any other questions from the audience. Are there any other questions you think we have for our speakers? If yes. Yeah. Sorry, I think you're on mute at the moment, Nathan. We can't hear you. Oh, I'm sorry. You have to unmute. Okay. So I think we should probably wrap up this session. I want to thank all the speakers for some wonderful talks today. And of course, my fellow moderators for their support in delivering this session. I'd like to encourage our audience, please, to provide the feedback that they can on the talks. It's very useful for both the speakers and for the society to know how well we've delivered this session. And just to remind you again, the audience to try and join the quiz, which is going to be at 6 p.m. later on online. Otherwise, I wish you all a very wonderful rest of the day. Thank you so much.
Thank you.
Thank you very much.
Thank you. Bye.
Bye.